Okay, so the studies have demonstrated that even a grade 2 pterygium may lead to 3 diopter with the rule astigmatism, and that causes a real problem. And excision of pterygium induces changes in both meridian, so that causes. Now this is an advanced pterygium that you can see. This is a big problem, and if it is associated with cataract, it leads to problem. The astigmatism caused is more, and therefore the power becomes difficult. This is another example of an advanced pterygium which is covering the pupillary area. This is again too much advanced pterygium, and here we have to be very careful in doing. If it is associated with cataract, we have to be very careful. So all these patients are usually of low socioeconomic strata, and people don't think that it is a big problem and keep on waiting till it covers the pupillary area and then come to us in rural areas. So that is a problem. And so therefore it's pterygium, as we all know, that it leads to astigmatism, and there could be some pre-existing astigmatism, and there could be a pterygium induced astigmatism also. So both these factors independently lead to a lot of astigmatism, and then we have to correct it. Patients of more than 50 years usually have against the rule astigmatism, although the pterygium induces with the rule astigmatism. So this can even negate the astigmatism. So depending on the astigmatism depends on the horizontal length, the length of the pterygium. More the length, more is the astigmatism, and the surface area, which is more, then it also leads to more astigmatism, and more the vascularity, more are chances that the astigmatism would be more. So this is there. And refraction in our setup, it's many a times it's not possible because the patients come with mature cataract, and if it is covering the pupillary area, you cannot do refraction. So the power cannot be done easily. So that is there. And how to measure the keratometry, the corneal power is important. You can do a manual keratometry or you can do a topography. But in many a times we have seen that the topography does not give you a good result, so we have to resort to manual keratometry. Now, so this astigmatism is reversible except in corneal disease. If you have pterygium induced astigmatism, if you do the surgery, it gets reversed. So repeat keratometry should be done once you have done the pterygium surgery. Later sequential cataract surgery is the idea here. So what you do is that you repeat the keratometry again after 4 to 6 weeks, and you look at the stability of the cornea. If it is there, then you can do a good keratometry and can get a good IOL power calculation. Based on that, you can implant the lens. Then so where the incision has to be made, it should be made on the steeper side. That is important. And one should avoid the pterygium area, that is also there. You should not give the incision there. You can go to the temporal side if it is other way around, or you can, better is to be on the vertical side because you get with the rule astigmatism with pterygium. Why sequential is better? Because as I have already mentioned that you can do a good keratometry, and that helps you. The same is true with the cataract and glaucoma. So simultaneous surgery many a time does not give you a good result, so that can be done. And same is true for cataract and pterygium also. Now, simultaneous surgery can be done if there is just a small pterygium, or astigmatism is not there, keratometry is equal in both the meridia, and you have to look at the regular Myers. If it is there, then you can do a simultaneous cataract and pterygium surgery. So that can be the option there. So this is how you do a pterygium surgery, and then 6 is planned here, incision is given here, and you can finally get a good result. And sometimes we need to put a graft also. So you can take a conjunctival graft or amniotic membrane graft can be taken. When you are taking from the graft from the conjunctiva, then you can just rotate. A rotational conjunctival graft can be taken, or You can take a autoconjunctival graft. If it is too large pterygium, then you can take a amniotic membrane, which would help in preventing the recurrence of the pterygium. So the tunnel, as I have already mentioned, because there is with the rule astigmatism, in a horizontal pterygium, you have to make it in the vertical area, 12 o'clock area, you make a incision, and based on that, you complete the surgery as usual you do in small incision cataract surgery. The incision causes about 1 to 1.5 diopter of surgically induced astigmatism. So it can easily correct the astigmatism which is pre-existing or which is there with the pterygium. So that is very helpful. Otherwise, if it is too much, then you can plan for a toric IOL there. Now, how to do IOL power? They say that if the pterygium size is larger than 2.4 millimeters, or the surface area is 5.45 square millimeter, then simultaneous surgery is planned. The implanted IOL power should be at least 0.5 diopter smaller. जो आपने कैलकुलेट करी है उससे कम कर देते हैं 0.5 diopter. So similarly, we reduce IOL power by 0.5 diopters in grade 2 and by 1 diopter in grade 3 pterygium, where the pterygium is slightly larger. There, the astigmatism caused is around by the pterygium is around 1 diopter, so that has to be reduced. This is a small video in a pterygium like this. So you do a normal pterygium first. It is a simultaneous surgery, so that you can be done. And pterygium is excised. A conjunctival autograft can be done, or in a small pterygium you can keep it just a bare sclera. And this is the autoconjunctival graft being taken. You measure the size there and then you do it. SICS is done in the usual fashion, making a frown incision and doing the SICS in the normal way. So this can be done, and regression formula have been proposed, but those are not very good. So these days modern formulas are there. You can do take those formulas for calculating the IOL power. And astigmatism management, as I've said, that simultaneous surgery can be done in a smaller pterygium. In a larger pterygium, sequential surgery is always better. So with these are the grade we have already discussed. So you can plan accordingly. Keratometry at times is very irregular in these cases. You can see, and you are not able to do this thing. And if you do a prior surgery, like in this case, the pterygium is there, and this is the topography. You can see there is so much of a steep axis here. And after the surgery, the this topography becomes like this, and you can see the astigmatism has reduced. So based on that, you can do IOL power calculation, and finally you can complete the surgery without any problem. Sequential is always better. In a smaller pterygium, you can plan a simultaneous surgery. Thank you so much.